So it's indeed a pleasure for me to introduce to you today Professor Vineet Bhandari, who's the Chief of Neonatology at the Children's Regional Hospital at Cooper Medical School of Rowan University, Camden, New Jersey, USA. Professor Bhandari has been an alumnus of PGI, and he did his MD and DM at Postgraduate Institute of Medical Education and Research. And he is going to be speaking today on prevention, management, and recent advances in bronchopulmonary dysplasia. And I would just like to tell you that he's highly cited and has done some seminal work in prevention and management of bronchopulmonary dysplasia, and he heads his own lab in this particular field. Professor Praveen Kumar has also joined. He is our Chief of Neonatology at PGI. He will be moderating questions later on when they come up. And Dr. Praveen, we would let you know them. Some of the questions will be coming in the chat box of Zoom, and some will be coming on YouTube. So those will have to be communicated from here. So Dr. Bhandari, if we can start now.
Sure. Thank you. Thank you, Minu, for the invitation. And it's always a pleasure to talk to folks in PGI. And I see some of my, well, I will say young friends, since they look very young, Praveen, Saurabh, Kanya, and it's so great to see all of you. So today's my talk should last about 45, 50 minutes or so. And I will be focusing on the prevention, management, and recent advances in BPD. I will be trying to be as precise and practical as possible to give you suggestions of how we manage babies, or at least how I manage babies to try in the different phases of BPD. And hopefully we'll have a nice interactive session at the end of the talk. So that we are on the same page, I'm going to be using the clinical definition of BPD. As you know, that there is a lot of I shall say, controversy and discussion about the different types of definitions of BPD. A recent paper like a couple of years ago talked about 18 different definitions of BPD. But for some of the studies that I will quote, they have used this standard definition of clinical BPD, which is the NIH definition of 2001, which is essentially you assess a baby at 36 weeks post-menstrual age. And if the baby has received oxygen for about 28 days, over the entire duration, at least 28 days, then depending on whether the baby is in room air or needs some oxygen or positive pressure support and or oxygen, the baby is classified into mild, moderate, and severe. Now, as BPD has evolved, as we have been getting better at saving smaller and smaller babies, as you are also aware, we are in the US, we have now started trying to save some 22-weekers, and Japan has been doing a very good job of saving 22-weekers up to 20 to 30% survival rates. In fact, the ACOG just took out a guideline, practice advisory guideline, saying that now antenatal steroid is suggested for babies between 2207 to 2267 after discussion with the family. So this new BPD is essentially something that happens in the newer or the more younger gestational age infants. It's a combination of genetic and environmental factors, and I'll talk a little bit more about them later. So you have these prenatal factors, which obviously includes genetic susceptibility, but there are other factors in the environment of the mother. For example, we have pregnancy-induced hypertension, infection, smoking. By infection, I'm referring to chorioamnionitis. And then after the birth of the baby, you have a combination of the environmental factors interacting with these prenatal factors, namely mechanical ventilation, specifically invasive mechanical ventilation that leads to volutrauma, barotrauma, electrotrauma, or if you want to put one word, biotrauma, leading to a release of many inflammatory cytokines. Then, of course, there is hyperoxia, which releases reactive oxygen species, leading to DNA damage, and protein and lipid peroxidation, again, leading to an inflammatory response. The combination of these prenatal factors, hyperoxia, invasive mechanical ventilation, acting on a foundation of the immature lung, leads to a persistent and inflammatory state. And this leads to aberrant tissue repair, which is characterized by inhibited vascular and alveolar development, causing the resultant of new BPD. To put it a little bit more simply over here, so we looked at 4 different groups or 4 different parts of the pie chart. So you can say there is placental insufficiency, lack of steroid infection, smoking among maternal factors. In the infant predisposition, you have genetic susceptibility, male sex, race. For example, white Caucasian race is more susceptible to BPD. Then I'll talk a little bit about the microbiome and of course sepsis. Now sepsis refers to prenatal factors like corium rhinitis and postnatal sepsis, where it could be locally, which is in the lung, pneumonia, and or of course systemic sepsis. And then mechanical ventilation, I already talked about these 3 factors, and oxygen injury. And the combination of this inflammatory state leads to an initiation of the process of BPD. Now, I always like to, and so this is the new BPD. I always like to think of BPD into 3 phases. We first mentioned this classification in 2009 and have a new paper coming out soon where we have again explained this a little bit more in more detail. So because we have to intervene at specific time points to make a difference in these babies, what I like to think of is the early phase, which is up to first postnatal week, normal to severe RDS, which is the classic initial presentation of these babies. However, you can have babies who may not require oxygen or may not require even, may require a little bit of non-invasive support with CPAP, and then they start becoming sick probably around day 5 to 7. So early phase does not necessarily mean they have to have RDS. It is just the immature lung being exposed to the environmental agents that can predispose or initiate the baby into BPD process. The evolving phase is more than first postnatal week to 36 weeks post-menstrual age. And here you have babies who have increasing respiratory distress and increasing oxygen requirement. The established phase, which is beyond 36 weeks post-menstrual age, you have tachypnea, dyspnea, crackles, stridor, the classic signs of respiratory distress and problems in a bigger baby. They have BPD spells. They can be evidence of pulmonary hypertension, GE reflux, and poor growth. And so when we talk about the management of these babies, we'll try to go over each one of these phases and the different parts of the management that can impact and hopefully try to ameliorate this condition from getting worse. For the prevention, I think the most important thing to remember is to administer antenatal steroids. Now, we do know that antenatal steroids do not prevent BPD as using the clinical definition. However, it has been shown that it has the benefit of decreasing RDS, which obviously makes it easier for babies to breathe and also helps us support the baby non-invasively. But in addition, it has other beneficial effects. It's been associated with a decrease in NEC, decrease in intraventricular hemorrhage. So I think it is important to try to remember to be friends with your groups, the maternal fetal medicine and the OBGYN, and remind them to please administer antenatal steroids. And of course, it takes about 48 hours to have its full action. So if they can delay preterm labor for at least that much time while the steroids get time to act, we will have a much better shape. The baby will be in a little bit better shape than what would have had happened had the baby not got antenatal steroids. Now we'll talk a little bit about ventilator strategies. Now, regarding ventilator strategies, the basic rule is not to do invasive ventilation. So this slide is actually worth, well, it's a picture, so it's 1,000 words, but I'll add 3 more words to it. And so it's now worth 1,003 words. So the effort should always be to avoid putting the tube. And if we need to put in the endotracheal tube, to try and get it out as soon as possible. In fact, I will not go into details about it, but we have data, we have shown that if you can try to get the tube out, especially between the 24 to 48 hours of life, and keep the tube out for at least a couple more days in the first week of life, we have shown that, at least on retrospective analysis, that the data suggests that you can interrupt the inflammatory state and potentially decrease the severity of BPD. And there is some not only experimental data, but human data to support that the inflammatory state that is initiated in the first few days of life, if it can be interrupted or made different, then you can make an impact on the final outcome of BPD. So in the early phase, in the first week of life, we avoid intubation. So right from birth, we are going to try to avoid intubation. Now, if we are going to give intubate, we will give early surfactant. By that, I mean less than 2 hours of postnatal life. If we are using surfactant, we right now are using the Ensure method, which is intubate, surfactant, and extubate. and we put the baby on nasal intermittent positive pressure ventilation, NIPPV. However, some of these babies are really small and you're not ready to extubate. So in that situation, we will ventilate the baby using short inspiratory time. Usually I use an inspiratory time of 0.35, 0.4 seconds. I use rates about 30 to 40 per minute. I'm trying to keep the pressure as low as possible. And I usually do not exceed PEEP beyond 7. And because there is data to suggest that volume guarantee ventilation is better than just pressure control or pressure SIMV mode. So we tend to use tidal volumes of 4 to 6 ml per kilogram, and then and try to titrate the FiO2 to keep saturations in the target zone that we'll talk about. The blood gas targets in the early phase we keep the pH around 7.25 to 7.35. In fact, I'm usually very happy even if the pH is 7.2, as long as all the other parameters are okay. PaO2 around 40 to 60 and PaCO2 45 to 55. I will even allow it to go up to 60 if necessary, especially in the end of the first week of life. We do not use high frequency ventilation as a primary mode. We use it in the rescue mode. By rescue mode, I refer to when if their baby has an air leak, either in the form of PIE or some form of pneumothorax. We will attempt extubation, especially like I said, within the first 24 hours or within 24 to 72 hours as much as possible. And when we extubate, we will extubate to NIPPV. We do not routinely extubate to CPAP anymore, as the data strongly suggests that NIPPV babies who are extubated to NIPPV tend to do better than the ones on CPAP. So when we are using non-invasive phase, now we go to the evolving phase. We hope we will have the baby on non-invasive support, and our blood targets, as you can see, have the CO2 range has moved up a little bit, and so has the PaO2 range a little bit. In the established fish, once again, if you're as much as possible using non-invasive support, and you can see the target range for the blood gas and the PaCO2. Now, so those are the essential elements of inventory strategy. Sepsis reduction is very, very important. And the strategy for sepsis reduction is essentially trying to decrease the amount of exposure to foreign bodies in the baby. So it means, again, taking the endotracheal tube out, limiting the use of, or at least trying to decrease the duration of the use of the umbilical catheter, and of course, same for the PICC catheter. For us, we use the umbilical artery catheters to around 5 days is when we start thinking of taking it out, but we have kept them in till about 10 days. If necessary for the smallest babies. For the UVC, our aim is to try and get it out by 10 days, but we will extend it to 14 days. And usually by that time, we are able to get a PICC line in, and then hopefully we'll get onto full feeds, or at least you're working towards full feeds. Oxygen is a very important pathogenic factor in the development of BPD. And so if you think of oxygen as a drug, it becomes important to try and control the use of it and monitor the use of it. And this is how we do it. So we start monitoring or controlling the use of oxygen right from the delivery room. For the preterm baby, the default FiO2 setting is 0.3 to 0.4. Usually we will start around 0.3. And we tend to use not so much of CPAP, we tend to actually use the TPs, which is like NIPPV, essentially a resuscitator. However, we do have a backup with the blow-by oxygen with a bag, which is set at 100%, just in case we need to really move a little bit faster than usual. Obviously, we follow the Dawson curves in terms of giving the baby time to get up to a specific amount of saturation. So by about 5 minutes, if the baby is up to 85%, and we will start then obviously decreasing the FiO2 at that point. So during the first few minutes of life, saturations of 70 to 80% is quite acceptable, as long as the heart rate is steady and baby is ventilating and SpO2 is increasing. So only if the FiO2 is less than 85% at 5 minutes. So you have to be patient. You have the clock in front of you on the APGAR timer. So don't rush it, wait it out. As long as the baby's heart rate is good, the baby looks obviously a little blue, and people are worried and they try to crank up the oxygen. But we would strongly recommend that you wait for the saturation to go up. And if they're not up by 5 minutes to 85% or so, then we will increase concentration. But again, when we increase the concentration by the blender, we'll increase by steps of 10% or so. Once the saturation is more than 93%, we then gradually decrease the oxygen concentration to maintain SpO2 in the recommended range. It is important to remember to decrease the FiO2, because once the baby looks pink and active, people sometimes forget that the baby is still on a higher concentration of oxygen at that point. As you are aware, even room air is hyperoxic for the preterm infant's lungs and the preterm baby brains and other parts of the body. All right, so we like to keep our targets around 89 to 94%. You probably have seen papers where they've talked about, and the controversy about low versus high, and most of the recommendations have used the numbers 90 to 95, 91 to 95. We tend to be a little bit more conservative, I suppose, keeping it around 89 to 94 with targets of 88 to 95%. And the reason for that is what we have found is that the nurses, we don't have the automated FiO2 saturation ventilators, where there's automated loop to control the FiO2 based on the saturations. It's still not FDA approved as far as I'm aware. We have found that they tend to keep the babies on the higher end anyway. So by doing this, we are hoping to try and decrease our incidence of BPD. We have a reasonably high rate of BPD in my unit right now. I've been here about 1.5 years, and I just got a new software where I can actually monitor the histograms. And I'm not aware if you have it in your NICU, but essentially over the last 24 hours, we can check how much is the baby maintaining the saturation within the range. And so every morning on round, we discuss it and say, why is the baby, the baby should be maintaining about 75% of the time within the range and about 12 and 13% above and below, respectively, approximately. And if the baby is not doing it, if it's most of the time, in fact, 90% of the time when I'm around, I usually see the baby is spending more than 70, 80, 90% of the time within or above range. That means the baby needs to be weaned. And that is important. So it's not just the FiO2, which the nurses are reasonably good at weaning, but it's also to decrease the pressure. And if you're on non-invasive support, we have a propensity towards keeping the baby on high flow cannula, even though the baby is in room air, and they will not wean the flow, even though the baby is maintaining saturation above or within the range 80-90% of the time. So again, it is a culture of trying to change the culture in the unit and the thinking process that a baby needs to be weaned if the baby's oxygen saturations are being maintained well. For babies who are more than 34 weeks or ROPs, that is not worrisome at this point. They have a saturation targets of 93 to 97% with alarm limits of 92 to 98%. Of course, these are referring essentially to preterm babies. Pharmacotherapies. All right, so once again, I want to reiterate the point that prevention of hypoxia and as a pulmonary vasodilator, obviously oxygen works, but it is a drug and it needs to be monitored and it needs to be and carefully regulated when you're using it. So during the early and evolving phases, we keep it on 89 to 94%. And unless there is, especially in the established phase, if you're concerned about pulmonary hypertension, we will keep it around 93 to 97%, and with the alarm limits of 92 to 98%. Methylxanthines. So this, of course, acts as a respiratory stimulant, and the classic drug is caffeine. Decreases diaphragmatic fatigability. It's a weak bronchodilator and diuretic, and it has been associated, caffeine has been associated with decreased BPD and also improved neurodevelopmental outcomes on long-term follow-up. A very nice study done by Barbara Schmidt and a colleague, the CAP trial. So we start caffeine right from the get-go. One of the books that we have published recently, I'll show that at the end. There's a whole chapter on caffeine written with my colleague Abhay. And we'd go over all the aspects of caffeine therapy, when to start, how to give it, how long to give it, and et cetera, et cetera. And, but from our practical perspective, when the baby is born, once we have the baby settled down and we have taken a blood sample, we give vitamin K, we give eye prophylaxis. Next, number 3 drug is ampicillin, number 4 drug is gentamicin, and the number 5th drug is caffeine. So we start caffeine right from the get-go within an hour or so of life. And I actually tend to keep caffeine on board till the baby is on some degree of respiratory support. Whether it's anything more than 2 liters of cannula, I will keep the baby on caffeine because of the effect on the diaphragm, and not so much the effect of the respiratory stimulant in that situation, because babies are usually older by that time. But the diaphragmatic action is very useful. And it is, and since the diaphragm is the most important breathing muscle for the baby, it becomes crucial to help the baby out as much as possible. The doses are given on your screen, and of course, you have to keep an eye on the feeding intolerance and tachycardia, which are known side effects, short-term side effects. However, the therapeutic index of caffeine is pretty big and pretty large. So it's a very safe drug. We very rarely monitor levels, and we just follow the babies clinically in case we need to increase the dose of caffeine. Vitamin A. Now, vitamin A has been studied in a randomized trial way back in 1999, published in NEJM. It was Tyson et al., where they found that a dose of 5,000 international units IM 3 times a week for 4 weeks was helpful in decreasing BPD. And I believe, if I remember correctly, you needed to treat about 14 to 15 babies to decrease one baby with BPD. Now, routinely, we are not using vitamin A. There have been studies where people have not been able to access vitamin A because of lack of supply chain issues, and they did not make a difference on BPD. So I think in your unit, if you have a situation where there is concern that maternal vitamin A status may be diminished, which would affect the status of the vitamin A in the baby, the treatment strategy is given on your screen. It has to be given IM. If people have tried different other regimens orally and stuff like that, but it really doesn't work because you don't reach therapeutic levels. So my bias is that if you are in a situation where there's maternal deficiency, i.e. leading to neonatal deficiency, and if you're not, and of course we do give vitamin A in the TPN, but if there's a concern for that, then this might be helpful, just like an extra boost to try and prevent BPD. But otherwise, the strategies to work on non-invasive support, manage the oxygen, manage the decreasing of sepsis, those will probably have a much more stronger impact. Using caffeine will have a much more stronger impact than using vitamin A. Diuretics. Now, diuretics do not decrease the incidence of BPD, but in the first couple of weeks of life, they really do help us out for transient improvement in lung function by decreasing pulmonary edema. And the doses are written and the drugs are written over here. Usually, I will not use it till I reach around week 2 or week 3 if I can avoid it. Sometimes the PDA will become problematic, and that one, using a furosemide does help. Once we are on full feed, we will use chlorothiazide and spironolactone. Most of the time, we're just using Diurel, which is chlorothiazide, and we'll go up in steps to do maximum dose of 40 milligram per kilogram per day, but it's given divided BID. Side effects include electrolyte abnormalities, nephrocalcinosis, especially with furosemide, and osteopenia of prematurity, because furosemide is a calciuric drug. I tend not to use furosemide even every other day, just because of the fact that it makes you lose a lot of calcium besides the electrolytes. And I usually have a better control of the electrolyte complications with Diurel and or adding aldactone if necessary. Bronchodilators. Now, bronchodilators usually do not really work in the early phase. It might have some effect in the late evolving phase and established phases. Albuterol is a drug of choice, and we use it via MDI with spacer device every 3 to 4 hours if we see a response. If we do not see a response, we'll try it, and if we find that the baby improves, we will use it around Q8 hourly or so, or initially, and then every 3 to 4 hours if we need to, as long as the side effects are not too troublesome. The other one is muscarinic antagonist, ipratropium bromide. Again, the dose is given 18 microgram per puff every 6 to 8 hours. They may be useful, especially if the babies are not very responsive to albuterol. Again, in most circumstances, I'm using them in the established phases of BPD. And by that time, usually I have involved the pediatric pulmonologist to help me out. And in that situation, they usually recommend us to try it and see if the baby gets better with that, at least temporarily. These are some of the drugs that are available. And again, the drugs in India may have different names, but I just thought I would share with you some of the different preparations that are available for both bronchodilators, the albuterol family, and the anticholinergic drugs listed here. Steroids. Now, steroids obviously are very powerful agents to decrease inflammation and pulmonary edema. We do not like to use steroids, especially in the first 3 weeks of life. I will try to push it out to about 4 weeks of life. And again, the reason for doing that is the association with neurodevelopmental outcomes being worse off in the ones who have been exposed to steroids early, especially if they've been used at a higher dose very early in life. We like to use what's the DART protocol, and here we are using it mostly to try and extubate the baby. The dosing regimen is given here. And at least in the current unit that I'm working in, the faculty it tends to almost prolong this to about 10 days, which I think if I will probably mention it down the line. There are some, there's been a meta-analysis which suggests that up to 8 days of, as long as you within the limits of the total amount of dexamethasone or steroid recommended, you're okay. But I personally like to use this 5-day regimen if I can keep the baby extubated and then try to extubate the baby within 48 hours of starting it, and then try hopefully keep the baby extubated using higher pressures and settings on non-invasive support as much as possible. If you have reached the established phase of BPD, which is beyond 36 weeks post-menstrual age, and you are in a situation where you are on some nasal cannula for 2 liters, 3 liters, you're receiving some oxygen, prednisolone might be helpful. The regimen is given over there, given 5 days, 3 days, and then every other day. So over a period of 8 to 10 days, what we have, there's been a paper publication where they have shown that it actually decreases the amount of oxygen being used, and you are able to potentially even get the baby home using this regimen. The short-term effects include hyperglycemia and hypertension, as you're probably also aware. What about the other factors that can make a difference in the outcome of BPD? So we tend to run our babies a little dry. I've actually written a recent editorial in Pediatric Research on this. I was just discussing a study that was published in the same issue. And so the first day we start around 80 and we go up by 20, maximum 140 by day 7. We tend to avoid sodium for the first few days of life, at least for the first 24 to at least 48 hours as much as possible. There will be some sodium, no matter what we do, like 1/4 in the UAC drip or the UVC drip, if depending upon which one is being used for the TPN. But if you try to keep the babies dry, especially in the first few days of life, there have been a couple of randomized trials that suggest that these babies do much better in terms of their final outcome of BPD. Nutrition, very, very critical. We will start with proteins right from as soon as the line gets in, and we can get what we call off-hours TPN. And we will start with 3 grams per day on the first day, and then we'll go up to 4 the next day. Within 24 hours, we'll start with fat of 1 gram, and then we'll go up to 3. And we will start with colostrum within 24 hours. If the mom is providing us with colostrum. If we can wait sometimes, if the mom doesn't have colostrum in the first 24 hours, we can wait 24 hours. But if as much as possible, we like to start our feeds as soon as the mother can give it to us. We have a donor breast milk program, so we always use as much as possible breast milk. So if the mom's own milk is not coming in, or as long as she gives us consent to use donor breast milk, we will use donor breast milk. Breast milk nutrition has been shown to be effective, has been associated with decreased incidence of BPD. And so we really concentrate a lot on giving breast milk as a nutritional support. And we try to aim at calories of 120 to 140 kilocalories per kilo per day. PDA. Now, PDA, we try to, the pendulum board initially used to be, everybody would be treating it. Then the pendulum shifted to the other extreme where we do only in some babies or not in some babies, and watch it and wait and what happens. I think the pendulum is now shifting back to the center, especially now that we have some effective drug and also we have coiling. So we usually will investigate for an echo when we think the baby is clinically symptomatic, or what we call clinically significant PDA. And then if the baby has hemodynamically significant PDA based on some echocardiographic measures, then we will use drugs. We will tend to use acetaminophen or Tylenol. Indomethacin or ibuprofen also are equally effective, but with indomethacin, we are always concerned that if these babies have been going to get exposed to steroids, then the risk of intestinal perforation is there. There is actually even a study from the Canadian group, the Neonatal Research Network of the Canadian NICUs, where they have associated the use of indomethacin and perforation if the steroids, antenatal steroids, had been given 7 days prior. So I think we try to avoid it if you are worried about blood pressure or we think we might have to use hydrocortisone or anything like that. If we do not close the ductus within 2 courses of whichever treatment we have used, sometimes we can, we can use Tylenol and then later on maybe use indomethacin. We will go for coiling, and we've had very good success with coiling. It's unlike doing PDA ligation. I've seen babies who will go on reasonably high, moderately high settings. They will go to the cardiac cath lab, and when they come back within 6 hours or so, have been actually able to extubate them on non-invasive support, and they don't have the cytokine storm that we had to deal with when they were getting surgical ligation. So I think we do have a strategy where we will try to counteract the effects of PDA if it's a problem. If it's not a problem, we're just going to watch and wait. All right, so that essentially is my suggestion or the way I handle or based on the data that's available. Like I mentioned, there'll be a recent publication coming out soon where we have gone into much more detail about how to manage the early evolving and established phases of BPD with all the with all the relative risk and p-values and everything else you might want to know. And so hopefully it'll come out in the next few weeks. Now let's move on to the recent advances in BPD. So the biomarkers has been a bit of a problematic situation because there have been such a long list of biomarkers that have been associated with BPD. And here, this is just a table that from our review in 2013 that we had published. And you will notice that they have cytokines, chemokines, adhesion molecules, growth factors, and stuff like that. The problem is, while they have been associated with BPD, they have just not moved into the clinical arena. And some of the reason, probably the reason it hasn't moved into the clinical arena is because they're not that easy to get to, especially if you're looking for tracheal aspirates. Like I mentioned, the focus is so much now on not keeping the tube in that the tube comes out even before we would use it. Then the other problem is that the turnaround time for getting some of these measurements it's not really in minutes or cannot be done at the bedside, which really hinders its development as a biomarker. So we have been looking for a better biomarker. So let me share with you some of the stuff that we have been doing recently. So proteomics. So this actually was a study done in Italy. What they did is they essentially tried to look for proteins that are found in the babies, and they categorize them into 23 to 25 weeks and 26 to 29 weeks. They've actually only been this one study that I'm aware of that has looked at proteomics. So there really has been no follow-up that I have seen recently. What we see over here that there have been a couple of molecules that are interesting. One of the things that I want to mention is Clickone, which is an ion channel, and Annexin III. As you can see, it was significantly different between the babies with severe BPD. We've actually done some work on Clickone in the research lab where we have the Clickone knockout mouse. And the data does suggest that it does have a role to play in the pathogenesis of BPD, but we haven't published that as yet, but we hopefully in the next year or so, we'll try to get it out. And again, this one is looking at the same molecules. And the one that I want to mention is again is Clickone and Annexin III seems to have an association with BPD, at least in one particular group of gestational age group of patients. Now, the next thing that I want to talk to you about is microbiomics. Now, this is a very hot topic, the microbiome, and this work was done with the help of colleagues in Alabama, Vivek Lal and Ambulwan, and very good friends and colleagues. And so what we were doing in this study is that we collected tracheal aspirates in the first few hours of life. I think, if I remember correctly, within 6 hours of life. And we wanted to see what was the microbiome in these tracheal aspirates. And you will notice don't so much focus on the types of bacteria. We'll talk about this a little bit more later. But what I want you to notice is the pattern of microbiome of the bugs, of the microorganism that you see over here. This is for full-term babies. These are ELBW infants who do not get BPD, and these are the BPD babies. At the very least, you can appreciate that the blue pattern is somewhat different between these three groups of infants. This, like I said, the samples were taken in the first few hours of life. And of course, the diagnosis of BPD was made at 36 weeks. In the figure B over here, you see that there is a difference in pattern of the Proteobacteria and Firmicutes in the full-term baby, the ELBW babies, and BPD babies. As you can see, the pattern of Firmicutes is much higher in the BPD babies. Now I want you to direct your attention to this figure, which is D, which is looking at what's called the Shannon Diversity Index. This is a very important observation, and this has been shown consistently in a lot of other papers, other investigators' papers too. What you will notice here, this is full-term babies, this is ELBW babies, and this is BPD babies. And you see the position of the Shannon Diversity Index is different in these three groups of infants. What is interesting is that the BPD babies, the types of microorganisms that you find, the variety is much less. That means the diversity index is very low compared to the full-term and the ELBW infants. So there seems to be this pattern of microorganisms in the BPD babies who are going to develop BPD, which is limited in number and variety. And we think that is one of the reasons why the pathogenicity of these bacteria can be contributing to the development of BPD. Then we started looking into what are the types of bugs that you find over here, and you will see the darker the shade of blue, which you can see over here, the more likely these organisms are found in this types in these babies. So you will see here that since you see this dark blues in the first three rows, they are referring to Staphylococcus, Escherichia, and Enterobacter. So you can see these pathogenic bacteria are much more commonly seen in the BPD babies compared to the full-term and the ELBW infants. Then we went on to try and see if this is a consistent response between two separate populations. So in the Alabama group, this was the discovery cohort. They had two groups of babies who were BPD resistant and another group that was BPD predisposed. Essentially, keep in mind that while we're collecting the tracheal aspects and checking the microbiome much early in life, within a few hours of life, the diagnosis of BPD is being made at a much later stage. And what we see over here that in the BPD resistant group, and again, the darker the shade of the brown, the more number of organisms of this particular species is found. And you will notice that the lactobacillus is much more common in the BPD resistant group compared to the BPD predisposed group. Once again, highlighting the fact that the diversity index is different. But over here, you will notice that in the babies who had been exposed to chorioamnionitis versus no chorioamnionitis, the amount of lactobacillus was much higher in the no chorioamnionitis group, which again suggests that, excuse me, which suggests that the lactobacillus may be having some kind of a protective impact, which was fascinating for us because obviously, as you would probably be aware, of the work that has been done on lactobacillus and prevention of NEC. In fact, we use in our unit probiotics routinely in all babies, the babies less than 1,500 grams, and that does contain lactobacillus. So anyway, even in the airway, we see that lactobacillus seems to be having some kind of protective role. Now, this is a discovery cohort that was done in Alabama. So then I shared the samples from my center, Philadelphia, and I sent to them, and they were blinded to the results. And lo and behold, we got exactly the same results in the validation cohort. And the best part is that neither Vivek nor Ambal knew which samples were BPD resistant and BPD predisposed. I just sent them numbers. And once they sent me which ones had more lactobacillus, we broke the code and it had the same pattern. So this puts some, I think it really reinforces the information that there is something in the microbiome that makes it more likely that a baby might get into BPD. And potentially one would think that maybe you can manipulate this kind of information and I don't know, maybe give some probiotics, lactobacillus in the airway using surfactant, for example, as a delivery vehicle to make sure that maybe an overgrowth of lactobacillus might be beneficial. So there is some experimental work going on in this direction. Now I'll move on to Metallobomics, and we've published two pieces. We've actually pioneered these kind of studies, and I'm going to share with you two of our studies. So the first study, we had 68 neonates with gestation age less than 30 weeks, and we had 44 with BPD and 24 without BPD, and we had collected tracheal aspirate samples on over the first week of life, and these are the numbers. This study is published, as you can see the reference over here. And in this pattern, what you will notice that there is a difference in the green and the red. So green, the red diamonds and the green squares. And the ones that are green squares are no BPD, and you can notice that they are congregated on this aspect of the pie, the left upper zone, my left upper area, upper zone of this pie chart. And so just by looking at the different variety of metabolites, we are able to pick up babies who go on to develop BPD versus no BPD. And so that makes it very interesting. Now, what are the metabolites that are differentiating the babies between BPD and no BPD? So we found that there were acyl carnitine abnormalities, which are associated with disorders of fatty acid oxidation. These usually are increased and they are considered pro-inflammatory. Then, of course, sphingolipids. And the data is not yet fully out whether they're pro or anti. Probably a ratio of these things may be important. And then we also noticed that the glycerophospholipids are increased in the babies who get on to develop BPD. And the one that really struck our attention was something called lysophosphatidyl-choline. Now, I will please remember this number, this name, lyso-PC, because I'll come back to it at the end of my talk. It's a phosphatidylcholine which is formed by the hydrolysis of phosphatidylcholine, which is part of surfactant, by the enzyme phospholipase A2. And it is known to trigger toll-like receptor inflammatory signaling. So it is a pro-inflammatory molecule. And we have detected this in the metabolite in the tracheal aspect in the first week of life. And we'll come back to that at the end of the talk. Now, in the second study, this was done with a group in Alabama. They used a different set of testing materials, so they have slightly different results. But what was interesting is that they also found that metabolites associated with fatty acid oxidation were abnormal, and also they found that metabolites associated with estrogen and androgen biosynthesis and metabolism were distinctly altered at birth. So this again could give us a pointer towards the fact that male babies are more predisposed to BPD, and this is again giving us a signal in that direction. Now, as I mentioned to you, inflammation is a key role to play in the pathogenesis of BPD, whether it's prenatal or postnatal. So the question is, the steroids that I mentioned to you are obviously a very powerful drug to try and break this inflammatory persistence. And this is a very nice study published by Ramaswamy in JAMA Peds this year. All these different abbreviations essentially refer to the duration and the dosing of steroids. So MO, MD, SC, DX basically stand for moderately dose and moderately duration. And I'll explain that. Of course, you can read the study. It's a very nicely detailed study looking at the different protocols and the different studies that have looked into the regimens that have been used to manage babies using steroids with BPD. And again, showing you that the moderately dosed and moderately duration seems to have favors the intervention. And I'll mention the duration in a minute. Here it is. So what the study basically essentially concluded that the most effective postnatal regimen for preventing risk of BPD or mortality at 36 weeks should be moderately early, 8 to 14 days. But like I said, I try to avoid using steroids till at least 3 weeks of postnatal life. Medium cumulative dose of 2 to 4 milligram per kilogram and short course of less than 8 days. As I mentioned to you, I tend to use steroids of dexamethasone, and I showed you the regimen of the DART protocol, which is from Australia, which is for 5 days, and sometimes we do extend it to 10 days, especially if you're finding a response but we are concerned that baby might go back to the endotracheal tube ventilation. However, keep in mind the low quality of evidence for these studies, and of course the risk of hypertension was also very obvious in these studies. One of the new things that is really exciting and coming up is looking at use of intratracheal budesonide and surfactant to prevent BPD. So far, we've had 2 clinical trials. A meta-analysis was published in Pediatric Pulmonology a couple of years ago. And what they found is the babies who had received budesonide surfactant mixture demonstrated a 43% reduction in the risk of BPD with a number needed to treat of 5, and mortality was not different. A 40% reduction was observed in the composite outcome of death of BPD. in the second study with number of needed creed of 3. So it seems that this might be something. It's only one dose of budesonide given really early, within 2 hours or so, or when they decide to give sulfite. I think the study said within 24 hours, but I have to confirm that information. So there is another trial that is ongoing right now. It's called the BIB trial, budesonide in babies, which is being spearheaded by the NICHD Neonatal Research Network. Amalwanan is the PI on that. So I believe, I have not talked to him recently, so I do not know how much progress has been made, but we're all looking forward to seeing the results of that study and seeing if it does make that dramatic an impact as these two studies have suggested. There have been some other retrospective studies using the combination of this. There are centers even in the US that actually have started already using this, which I think I would be a little uncomfortable doing it based on the data as yet, but at least, and since they have published it, here's some information. In this group of babies, they found no difference in short-term outcomes. In this retrospective study, no difference in BPD. In this study by Cohort et al., they had 173 treated and 294 historical cohort. This is the group, this is the center that is using it routinely in their unit. They found no change in the overall rate of BPD, but the treatment group had less need for mechanical ventilation, severe type 2 BPD or death, grade 3 BPD or death, and GA discharge was 1 week earlier. And they found it was safe in the sense that they did not find a difference in neurodevelopmental outcome at 6 or 18 months corrected. However, I would recommend that or suggest that we would probably wait for the big trial that is ongoing and then decide whether this would be an effective therapeutic option for babies for us to use in babies. Another very interesting approach is using NIPPV with MIST or LISA. MIST stands for minimally invasive surfactant therapy. LISA stands for less invasive surfactant administration. So you can use either a feeding tube or a vascular catheter. There has been one study, a big study that has been finished by Peter Dargaville's group from Tasmania. I believe it's going to get published soon in JAMA. They did not reach the full sample size because of COVID, but as far as I recall, the data, at least when they presented at the PAS meeting earlier this year, was very suggestive of, was strongly suggestive of having an improved effect. So in this study from Turkey, what the group and Ansel et al. Had done, they actually combined using MIST and LISA with NIPPV, compared it with using with CPAP, using the same approach. And this is the demographic and information, which was showing that the randomization worked really well. There are 100 babies in each group, and they're very well matched. And we will notice here that in the group that had the NIPPV with MIST and LISA compared to CPAP, had a better outcome in terms of decreased need for invasive ventilation and decreased need for surfactant, and also had better outcome in terms of duration of supplemental oxygen and overall rate of intubation. So that is another approach that might be suggestive to think about in the future. This is just a comparison of some of the studies that they had done. Other people who have also used NIPPV, but this is the only group that actually has used NIPPV and surfactant. So potentially one can start thinking about using this kind of an approach where you would have a baby that you can use MIST or LISA and then support the baby with NIPPV, and perhaps depending upon the outcome of the trial, one could say maybe you could be adding budesonide with the surfactant to see if it can make an impact. And maybe in the future, we could probably even add lactobacillus, who knows? So we will have to watch and wait to see where that goes. All right, so I'm going to start now concluding the talk. So to highlight some of the issues, some of the findings we have shown with the microbiome, microbial colonization is low at birth. There is definitely some, this is from another study from the UK where there is, I did not go into details of that, but the reference is given at the bottom. There is dissimilarity between upper and lower airways in gut and BPD, and the dysbiotic inflammatory process in the lower airways is seen in babies who go on to develop BPD, and specifically, as I mentioned to you, they have less diversity and they have more amount of pathogenic organisms, which we will mention again in a minute. Pulmonary inflammation occurs despite being on usual antibiotics, which is AMP and GEND. Now, and one thought is that uroplasma and mycoplasma are not usually susceptible to these usual antibiotics. Maybe they are also, that's the reason they are also found more often in the babies who are predisposed to BPD. In our studies, we have shown that the colonization of the airway lung starts in utero, which actually, I believe we are the first one to actually show that the fetal airway is not sterile, even with an intact membranes. So that's, I think, an important finding. Again, I want to mention the fact that there is decreased microbial diversity in BPD. Longitudinal but not cross-sectional analysis may differentiate between severity of BPD. Again, I did not go into details of that, but it is there in our paper. And in our study and some other studies, we have found there's increase in Staphylococcus and Uroplasma species. And the ones who do not get BPD, we have noted an increase in Lactobacillus species, which, as you know, is supposed to be the good bacteria. Of course, most studies are required, but it is, I think, a very exciting time to look forward to in the near future regarding microbiome studies. Moving along to the Metallobomics, we found that the metabolites that are affected with fatty acid oxidation and carnitine are important in the ones who are predisposed to BPD, especially sphingomyelin and lysophosphatidylcholine, which are parts of the surfactant, and some metabolites associated with estrogen and androgen. They may be potentially useful to identify infants who develop BPD. Now, you will recall I mentioned to you that please remember lyso-PC. So while we were doing our studies, when I was writing up the paper with my colleagues, what we found, we came across this very interesting study published in Journal Pediatrics in 2015, much before our own study got published. What the investigators in this in Italian group, what they did is they took adolescents, these are teenagers with BPD, 20 and 15 with the healthy controls. And they studied something called exhaled breath condensate, essentially exhaled air, so to speak. And they did metabolomics on that. And what they found that in the BPD group, there was increased amount of phosphatidylcholine, lyso-PC, platelet activating factor, and unsaturated phosphatidylcholine. So what it really sounds very interesting, that's a defect, or shall I put it this way, some kind of an issue with the surfactant metabolism, or specifically with lyso-PC, which we detected within the first week of life, stayed persistent in the airway/lung of these babies, and who are now teenagers, for 18, 20 years. So that makes me think that this molecule is very important, or whatever this molecule does, or whatever it is supposed to do, seems to have some impact, that it stays persistently abnormal even after 18 to 20 years. And as we all know, that BPD is not a disease only in preterm babies, it is a disease for life. We have now seen baby children and adults, 30, 40, 50 years of age, who are more predisposed to COPD and stuff. And people have shown that their lung function and their imaging studies are abnormal. So I think it's important to remember that something that we are doing, or something happening to these babies so soon after birth, seems to persist. And so I would like to believe that the corollary is true, that if we are able to intervene right in the beginning, within the first few hours, the days of life, we will make a difference, and of course try to give these babies who will become healthy children and adolescents and adults a much more healthier state of the lungs. For proteomics, like I said, there's been one study that I talked about before. There's one other study, Umbel's group has done it in the urine. But I have not seen any recent studies following up on that. Steroids, we would recommend you use moderately earlier, medium cumulative dose, short course, and we prefer dexamethasone. Intratracheal approach is very promising and requires a larger study, which is ongoing, so let's wait for that. Similarly, using combination of NIP, NIPPV and surfactant delivery by MIST or LISA also seems promising, but I think we will need some additional information about this. I would like to thank the folks who have been very kind and been friends for a very, very long time, and hopefully many more years to come. Vivek and Umbel from Alabama. Zubair has been my collaborator at Jefferson. He actually used to work at Cooper, and then he left to join Jefferson. And now I'm at Cooper, but we still collaborate. Fiammetta was from Italy, and she spent a year in my lab, and she did the work along with Tuket Lam, who did the analysis at Yale when I was working over there. With that, I'll be happy to take questions. I would also like to suggest that if somebody is really keen on picking up more stuff that we have talked about here, there are a couple of books and chapters that we have written. The last book is The Tantalizing Therapeutics, where we have looked at various new stuff. Like I didn't get a chance to talk about microRNAs, I didn't get a chance to talk about macrophage, migration inhibiting factor, etc., and more details about caffeine. They're all available if you're interested, or you can just email me. I'm happy to give you links for these things. Thank you so much. This is my hospital, and here I'm taking care of a baby and talking to a mother too. So happy to take questions.
Thank you very much, Vineet, for such an excellent insight into mechanisms, prevention, and management of BPD. Some of the therapies actually do look very familiar. And I do wonder if we are using them here. So I'll hand you over to now Dr. Praveen Kumar. He'll be moderating the questions. There are a few questions in the chat box, which I think Dr. Praveen must have seen. And Vineet, you can also have a look at them. And we can start with the question answer session.
Thank you, Vineet, for this, as usual, very energetic and comprehensive yet insightful talk. And it's always a pleasure to listen to your new research and new direction, especially for BPD. So we have a few questions in the chat box. And so Biju wants to know, maybe in case you did not start caffeine to begin with, and you have a case of established severe BPD with severe pulmonary hypertension, then is there any role of starting with methyl?
Okay. So like I said, I'm very fond of caffeine. Hopefully you would have started caffeine earlier, like we have suggested. But yes, if a baby is at severe BPD, you happen to be getting a referral baby like that, I will use it. Not so much for the pulmonary hypertension part of it, but like I mentioned to you, it has an effect on the diaphragm. It acts through the ryanodine receptors. And that's a separate effect from the usual effect on the lung that you are aware of. And so, yes, I would recommend you use it, and it does help.
Thank you. A couple of questions related to the issue of managing BPD spells.
Yeah.
And it's obviously a very difficult situation when one is faced with such a baby. And we keep trying different things. So maybe you can elaborate a little bit on how do you manage these spells. Sure. And especially if there's any role of HFO, and maybe I think somebody's asking a couple of drugs maybe. Yeah, so you can elaborate on BPD.
Yeah. So yeah, thank you for that question. Very challenging BPD spells, and all of us have had to deal with this. I'll tell you, the main thing that you have to remember when a baby is throwing off a BPD spell, sedate the baby. I think the instinctive reaction for most of us is to, or especially if they are trainees here, is to go there and try to bag and give bronchodilators and stuff. Sometimes you're going to make it worse, because what happens with these babies is they become very restless, and they can actually, if they have significant amount of bronchotracheal malacia, by giving albuterol, you're going to actually make the condition even worse. So we focus on getting the baby sedated. Think of it like a TOF spell, like a tetralogy of fellow spell. So we will sedate the baby. We will give morphine as quickly as we can and calm the baby down. And of course, we have control of the breathing and support if we need to do that. So we all have the bag and mask. If we need to, if the baby is not intubated, we can always intubate the baby. But we focus on sedating the baby, and sometimes we even have to paralyze the baby. I am not aware of any high frequency oscillation trial for babies having BPD spells. I'm not aware of any study or even a retrospective study that has shown if it's helpful in these babies. Like I said, I will intubate the babies, and if I need to, I'll sedate the babies, and I will use SIMV. Yeah, and in fact, we have used NAVA on these babies, the NAVA non-invasive or invasive NAVA, and we have found that synchronization does have an impact on making the babies better. Ketamine, no experience as such. Vecuronium for paralysis, I would have used it only after, if I've not been able to get use of either fentanyl or morphine to sedate the baby. Next step, we would use intermittent Versed, and if we do not get the response, alternating Versed and morphine every 2 hours, and if you're still getting into a problem, then I would consider paralyzing the baby.
Thank you. Thank you. There's a question about prediction. Now, we have various predictors and all. So any role of lung ultrasound in early phase? can you predict, okay, this baby might go on to have?
Lung ultrasound is a fascinating, modality of intervention. Of diagnosis and potential prediction. I personally have no experience with lung ultrasound. I don't have, radiologist keen on doing it in our place. But at least based on the papers that I've read, it seems to be interesting in terms of trying to decide about RDS, severity of RDS, and the need for surfactant. There's a paper which actually tries to predict based on lung ultrasound scores. I am not convinced as yet that it is useful predicting BPD. And my bias is probably won't be very useful because BPD is a lot more other players in play, so to speak. And I don't think lung ultrasound by itself will be sufficient. Maybe in combination with something else, like another biomarker, I would probably put in this. Yeah.
So Sajal, who asked this question, has another question. Because you raised the issue of urea plasma, mycoplasma as possible, etiologic agents. So is there any role of macrolides for prevention or treatment?
Okay. So, there have been multiple studies on that, and I'm sure you're aware of the one that is the most recent, with Viscardi and Umbel being co-authors on that study, and they did not find a difference. The way I look at with using macrolide antibiotics, so I do not routinely use them. The problem has been in trying to pick up the diagnosis quickly. Now, we do have RT-PCRs, but because using culture techniques is really not, it takes too long. And the problems, they had the same problem in the study is that they gave it to everybody, but there were babies who never had uroplasma to start off with, and they got exposed to these drugs, which also have side effects. So I think till we are able to diagnose it early enough and do a targeted treatment, we will not know the answer whether it's useful or not. What I believe is that these bugs, uroplasma, mycoplasma family, they tend to have low-grade inflammation. So if you're a 25, 26 weeker and you have inflammation, some degree of inflammation baseline because you are intubated, for example, then what happens is that if you have on top of, and if you are doing all the other things to prevent BPD, you add the uroplasma in the mixture, then I think it makes you go over the edge. And so in those kind of babies, it potentially would be helpful. But I don't have data to back up what I'm trying to say. I think the only way to answer this question is if we could pick up babies, send the tracheal aspirate culture within birth, within a few hours of birth, get the result within a few hours, and then randomize them to get treatment or not treatment, and then see, and give treatment only the ones that have it, obviously, and then see if it makes a difference. So at the moment, no, but I'm not ruling it out either.
So Dr. Sarjan has a question about the microbiomics. That what are the possible reasons for lesser diversity you found on the microbiome?
Yeah, so I think it is the same as in the gut. What happens is that some of these microorganisms are much more powerful in replicating. So if you are giving antibiotics, which we give antibiotics, some of these antibiotics kill the more susceptible good bugs, so to speak, and allow the pathogenic bugs, which maybe inherently have some resistance, or they have developed resistance to try and survive in that environment, and they tend to multiply a lot more. And so when they multiply, they use up all the nutrients and everything else and overwhelm the airway system so that the other bacteria cannot get a foothold in it. So that's the way, that is the reason, what I believe is because of cause there's less diversity in the babies who go on to develop BPD.
Thank you. Sajan has another question related to antenatal steroids. That why that antenatal steroids do not reduce BPD? Is it simply because mortality comes down, we have more preterm surviving, or there's something more than that?
Yeah, I think because keep in mind when you use antenatal steroids, the benefit effect of it is probably lasts for a few days. But BPD is such a disease that is in early evolving phases, and so the other factors are probably playing a role that overwhelmed the potential benefit of antenatal steroids. I still do believe, and I mentioned it, that even though it's not been shown to prevent BPD in the characteristic sense, I still believe that the beneficial effects are so much of that I would highly recommend it be used, and preferably at least if you can prevent the delivery for 48 hours, that'll be great. And at least it gives us an opportunity to use non-invasive support and try and decrease the inflammation and the persistence of the inflammation in the babies predisposed to BPD.
Dr. Venkat wants to know that, because we've been trying different things over the years and over the decades. So possibly, maybe it's a combination of factors. And can we try something as a combined approach or combined therapy to prevent BPD?
Yeah, I think, Venkat, that is probably the best way to do right now. So what I try to do is try to get the babies, control the oxygen exposure as much as possible right from the birth, and control the exposure to invasive ventilation. Try to do non-invasive support, give breast milk feeds. If you have access to vitamin A, you can consider that. Give caffeine. So I think, we've done it. So we've decreased BPD, and there are lots of studies that have done, with QI bundles and stuff to decrease BPD. Again, people have used a combination of factors, and in the individual unit, if you look at all these factors that I've mentioned and you make intervention for each one of them and combine them in a bundle to make a difference, you will make a difference. I will promise you that. It just requires persistence, and you have to have a champion. And so if you want to be the champion in your unit, go for it. You will make a difference.
And Venkat also had another question. We are using CPAP in preterm, then often there's a practice of, keep the CPAP on till 30 weeks gestation or 31 weeks gestation, with the idea, let the lung grow, let the baby stabilize. So is there any role of CPAP to keep the lung open or make it grow? And if so, how much CPAP and for how long?
Okay, so my answer to that is I don't personally believe that there is a role for this. People have shown data, and it's animal data is there, and there is, anytime, even non-invasive support that you're using, you're going to be creating, when you're distending it beyond a certain amount, you're going to create some problems because there is going to be some inflammation. It is a foreign body sitting in the nose, for example. So I do not believe in using CPAP. Just if I can get the baby into room air and nasal cannula and out of the support, I will go for that. I do not keep a baby on CPAP for lung growth. I always try to get rid of any foreign body in the baby and any kind of positive pressure, even if it's non-invasive, as soon as feasible. And I focus on nutrition to give the growth rather than positive pressure.
Thank you. So Kanya wants to know that is the pathology of BPD in higher gestation babies, which are commonly seen in India, is it different, like that? Maybe it's like old BPD compared to what you've seen?
Yeah, I think the pathology is somewhat different because, at least in India, if you're talking about, you are maybe dealing with situation with small for gestational age babies, smoking, nutritional deficiencies in the mother. And keep in mind, SGA per se itself has the association of increased BPD, and more importantly, increased amount of BPD with pulmonary hypertension. And there are certain placental factors people have suggested that can affect your angiogenic growth and vascular development, which predisposes the babies to this kind of a problem. So yes, I think that's a different pathology. And that's actually a separate talk some other day, BPD and pulmonary hypertension, yeah.
And then Vishal wants to know, is there any role of hydrocortisone during BPD spells? Okay. And how do you administer the inhalational drugs using MDIs to ventilated babies?
Yeah,
any special
so Vishal, not to my knowledge, and I do not believe there's any role of hydrocortisone. Of course, if a baby has established BPD, we will use inhaled steroids. Usually when we involve the pediatric pulmonologist, we would be using inhaled steroids. Inhaled steroids take anywhere from 2 to 6 weeks to really start acting well. And pulmonologists would tend to continue it for just like they treat with asthma patients. How do I administer it? By using an MDI and spacer. I will recommend if you just put in my name and put in we did a randomized trial where we compared nebulized versus spacer, and we showed that the delivery is better. This is in the NICU. Obviously, you can talk to your pulmonologist, and the spacer device definitely helps in delivering the drug better in bigger babies. But if you put my name, and if you have a problem getting the article, just email me. It's Bhandari-Vineet@cooperhealth.edu, and I can send you the paper that gives you a description of how we use the MDI and spacer.
Thank you. And then Saurabh, who has done a lot of work on gut microbiome, so wants to know what is the possible role of lactobacillus in tracheal microbiome, where it does not have a substrate.
The shortest answer, Saurabh, is I don't know. This is just an observation we found. I do know that Vivek, for example, Vivek Lal, he's the chief scientist of a company where they have used a combination of probiotics to try and do some changes in the microbiome of the trachea, of the upper airway. I don't know what it is doing over there, but that association has come out so nicely and strongly in 2 different cohorts, so I do not want to ignore it. I haven't personally done any work on this thing, But I would like to try this out in an experimental model to see if it makes a difference.
And then, did you have a question regarding cumulative dose of steroids? I know you mentioned you're not fond of steroids, but in case you do use, then what sort of doses would you consider acceptable?
Yeah. So I like to, as I mentioned to you, I mentioned the dexamethasone, and I gave you the description of the DART protocol. Like I said, we go maximum up to 10 days on that if we need to. But usually cumulative doses of 2 to 4 milligram per kilogram is what is recommended. And then, of course, I gave you the regimen for the prednisolone course in established BPD if you're trying to get a baby off oxygen. I would say, Biju, if you read the Ramasamy paper, it's a very nice detailed paper in JAMA Pediatrics. It goes through a lot of information. You'll find it easy. If you have a problem in getting access to that paper, just email me and I'll send you a copy, PDF.
We did have a journal club on that paper recently.
Okay, there you go. So yeah, just go over it again. It's a very nice paper.
So are you using a BPD risk calculator to decide which baby gets steroid?
No. So my approach for that is that I basically say, if I'm not able to extubate the baby, and trust me, I try my best within the first few days of life to get the kid off. If the PDA is a problem in the week or 10 days of life, then I'm attacking the PDA, diuretics or whatever I can try. And if I'm not being able to extubate the baby by week 3 of life, that is when I will start considering steroids. So the effect, my reasoning for using steroids is not to prevent BPD, is to get the baby, the ET tube out and keep it out. That's my focus. Yeah.
And then, Vineet, how commonly are you facing the problem of tracheobronchomalacia, and how do you diagnose it?
Yeah, I think. Yeah. So with tracheobronchomalacia, the trick here is increasing PEEP. And I actually didn't go into the details of how to manage severe BPD. But one thing you have to be careful with these babies is you should not be scared of increasing PEEP. I have gone up to, I know you'll probably fall off the chair, 17, 18 on the PEEP on a full, obviously these are bigger babies, 44 weeks, 48 weeks, right? To open up this thing. In centers that are referral centers like Nationwide Children's Hospital of Philadelphia, they see a lot of these babies and they actually titrate. So they can put a bronchoscope and they basically titrate the amount of PEEP, and then you keep giving the PEEP till you see the bronchus open up. And so that is how they figure out what PEEP to use. But you can do it clinically too. Just not be scared, but keep increasing it slowly. 8, 10, 12. 10, 12 are reasonably normal values for a big baby with severe BPD. They're very nice papers. The book I showed you on ventilation by Rajiv and Satyan, as part of the editorial team, there in that book, we have written a chapter on BPD. We described all of this. And you can also read Abman's papers on how to manage severe BPD. Abman's and Leif Nelin, Nelin. They've written some very nice articles on this.
I think what Venkat wanted to know was maybe it mimics BPD spell, and can we differentiate, and would the approach be different?
Yeah. So for me, whenever I see a baby trying to die on me by becoming blue, the first thing I will do is I'll sedate the kid. Once I sedate the kid, then I'm going to give positive pressure and try to open up the lungs. So when I'm doing that, if the baby is on the intubated, then I'll crank up the settings, PIP and PEEP. If I'm bagging, then I will use my PIP and by hand, I will figure out how much the baby needs to open up the chest. And if I need a higher PEEP, I know this baby has bronchomalacia. In most situations, these babies, we've got the ENT to come and take a look, and they will tell us if the baby has it. And so again, in centers that are have a larger volume of such patients, they do bronchoscopy. I don't have the ability to do bronchoscopy in my unit right now, but those centers can do bronchoscopy, and they can figure out how much, if the baby has bronchomalacia, and what PEEP is required to open up the airway.
Thank you. And we have a couple of comments from Professor Sam Rajadurai, who is actually basically supporting what you answered. That high frequency would make the baby worse in babies who are having spells. I think you also mentioned that. And macrolides, if given universally, may kill all the healthy microbiome also. So again, supporting your statement that you have to be very selective. So there's a question about any role of magnesium sulfate in BPD spell, which is commonly used in our country.
Yeah, I actually have not seen a paper on that. It'll be nice if somebody published it. Now, magnesium sulfate is obviously known to be a bronchodilator. I have personally not used it. I have not really seen a good paper on its use. I would strongly recommend if you people who have experience with it, publish it. And then, something that could be, I mean, it has biological plausibility. I just don't have any experience with it. So I can't really comment on it. And I've not read about it. So
what is the current understanding of the pathogenesis of BPD spell? What exactly is happening? So that would help us decide what to try.
Yeah. So, I mean, if you're talking about related to magnesium sulfate, Praveen?
NAC or other bronchodilator or sedative.
Yeah.
So what is the underlying?
Yeah. So I think these drugs can potentially be useful only in established BPD because, as you're aware, in the babies that are much younger, they don't really have the airway. They don't have the smooth muscle to respond to any kind of a drug that you use. And what we have found is that it varies very variable. Some babies respond nicely to the bronchodilator, even established BPD. Some babies just become more restless and clamp down. So I think we have to take it individually. I don't know how to separate these babies out except just try it out and see what happens. So I think as BPD is a very, I don't want to use the word waste paper basket diagnosis, but BPD is a very complex issue and they have different clinical phenotypes. There are some phenotypes that are more prone towards the asthma phenotype, which is the one that will probably may respond. And some phenotypes, they have more alveolar problem. Some phenotypes, the one that are associated with pulmonary hypertension, more of a vascular phenotype. So there are different phenotypes and degrees of the damage to the lung and repair to the lung. And I think each baby is a little different. And I just try it out and see what happens. But that's the way I would answer your question.
And then the question about ventilation strategy in BPD. So Sajjal is asking whether you would use high PEEP, low rates, prolonged TI.
Oh, yes, absolutely. Yeah. So again, I would recommend you to take a look at the chapter in Rajiv's book and or Steve Abman. And so essentially, you have to be careful. You have to look at whether you have most of the atelectatic type of BPD, severe BPD or cystic type of severe BPD. And so you have to titrate it. In the ones that are atelectated, they're the one I really crank up the PEEP. And I will use low rates and prolonged because here I have an oxygenation problem. In the cystic feed, I will use a separate approach. Again, Abman's paper has some very nice graphics. Even Rajiv's, chapter, the book where we have written the chapter on BPD, we have some nice graphics there that can probably help you with that.
Thank you. So I think it has been really wonderful, really raising many questions and maybe many ideas. And Saurabh has made a comment that we are already looking at the Maxwell's role using our retrospective records. And I think in our country, you did mention infection as one of the possible associations. But in our country, I think both maternal infection as well as neonatal infections have a very, very important role to play apart from nutrition. And in fact, it's very interesting that studies which are currently looking at cause of deaths in the community by doing all the PCR and trying to find out organisms which are generally not found, find a very high incidence of really pathogenic bacteria and maybe some viruses also. So there may be potentially a role there. And recently there's some kind of a new paper which came from Tyson about vitamin A. They were trying to reanalyze their original trial, and what they have claimed that vitamin A is possibly successful in those who have a lower risk of BPD compared to those who have a high risk of BPD. Yeah. So I think there's another line which is reopening maybe, and there may be not only deficiency of vitamin A, but maybe vitamin A has other effects which might be working.
Possible. Yes, that is possible. Yeah.
So thank you very much. I think
there was a question on YouTube, Praveen. This was about any recommendations for probiotics in prevention of BPD?
So let me put this, this is all experimental work that we're talking about the airway probiotics. Now, as I mentioned to you, we are using probiotics in our unit right now routinely. But we are doing it for the sake of trying to prevent any CRT.
Is that oral or that's intratracheal?
Oral, not intratracheal, oral.
Yeah, because
given to the gut.
oral, I think, can go into trachea as well. Like,
Exactly.
the
So I was just
bacteria
going
which
to
will just move. Yeah.
Yeah, so I don't know. So we actually have not tested in our, again, because we don't keep our babies intubated for a long time, so we haven't really, but one would think that if you have bacteria, probiotics, good bacteria in the gut, it will translocate somehow or the other to the airway, which might also help. I am not aware of any human study that they have given intratracheal probiotic as of now, to the best of my knowledge. But yeah, I mean, the Europeans and Australians have been using probiotics for a very long time now. Compared, USA is still, I think, trying to catch up, and they have made a big difference in the NEC rates. So because our NEC rates are higher, and knock on wood, I can tell you, since we started using it, like this year, we have only had 2 cases of NEC the entire year so far. So, we are, of course, we have also done donor breast milk and feeding protocols and stuff like that. So I don't want to just put the credit to probiotics, but I think it really works.
Breast milk is a probiotic, isn't it? That's the best natural probiotic. Breast milk is a probiotic.
Oh, yes, yeah, and breast milk. And like I mentioned, we have donor breast milk program in our unit. Yeah, we established.
Another, you'd mentioned about genetic factors for BPD, and I guess you have done a lot of work on microRNA, its role in BPD causation. Would you like to tell us something about that?
Yeah, so I think, so microRNAs are, very powerful agents because they can, and microRNAs, RNA is hot right now with COVID and everything else. One of the ones that we have worked on is microRNA 34A. And we've actually used inhibitors of microRNA 34A in a mouse model. And we've actually knocked out microRNA 34A in the type 2 cells of the lung, as well as used a knockout mouse to show that they are protected from BPD. Experimental BPD. We have moved to the next level. We have just recently published a study where we have used microRNA in a preterm rabbit model of BPD. And we actually delivered microRNA inhibitor with surfactant in this model. That has also been recently published. If you put my name and put microRNA 34A, you'll get the papers, or just email me and I'll send it to you. And so we are very excited. I am trying to work with the collaborator that I want to use it in a lamb model. And I just need some funding. And if that works, then hopefully I want to try and take it to the human. So I think it is very exciting. And the thing about microRNA 34, and again, we have published a review article on this, it controls a variety of molecules downstream, angiogenic, inflammatory, cell death, and so many things. So we think it's a very powerful regulator, and we can titrate the dose. We can decrease the effect of microRNA 30%, 60%, 100%, depending upon how much dose of the inhibitor we use. So I think there is a lot of experimental scope. The book in Tantalizing Therapeutics, we talk about microRNA, separate chapter on it. Go ahead and take a look at it if you want more information. But yeah, exciting, very exciting. Yeah.
Okay, thank you. Any other questions, Dr. Praveen?
Professor Sam has given an update that he knows of a meta-analysis of 36 trials of enteral probiotics, which did not reduce BPD rates.
Yeah. So I just have to be careful in this, because the variety of probiotics that have been used for NEC is a whole different dosing types of, bifido, whatever. So what I'm really interested is this combination of the lactobacillus, if it contains lactobacillus and stuff. And like I mentioned, Vivek is working. He has a patented group of bacteria that he's using as a probiotic to try and make an impact on BPD. So we'll just have to watch out for that. So.
Yeah, there was a study in Lancet actually, which talked about symbiotics for prevention of respiratory problems in newborns.
Yeah. So that'd be interesting.
So that's also something. So I think we've exhausted all the questions, and thank you very much for being with us on this early morning. I know what's the time right now with you. It must be around.
It's about 7:30. Luckily,
okay,
I'm used to waking up early. I got trained very well in PGI.
Okay. Thank you so much for being with us. And thank you, Praveen, for moderating the questions, and for everyone for participating. This talk will be there on YouTube for some time. And thank you very much. We'd like to have you again. Yeah.
Yes, sure, not a problem. And so nice to see Praveen and Saurabh and Kanya and Shiv Sajan and everybody else. Thank you so much. Have a lovely day. Bye-bye.
Thank you very much.